Your suture can turn a clean surgery into a slow burn irritant. So today we're going to talk about which threads harbor biofilm, which knots hold, and what actually lowers inflammation so your flaps stay closed and your patients heal clean. So the oral cavity, as we know, is a wet, microbe-dense field. Every suture becomes a scaffold for plug. Material, filament type, knot designed, change biofilm, tissue reaction, and dehiscence risk. So we'll talk about evidence first and opinions later. So what drives inflammation? There are three levers that drive inflammation. Number one, material and filament. Braided silk, for example, shows more plug retention and stronger inflammation compared to monofilaments. Monofilaments show lower bacterial load but can trade off knot security. So you have to adjust your throws and tail length. Surface and coatings. Coatings reduce surgical site infection in general surgery, but in oral surgery, specific data are mixed. Some dental implant randomized clinical studies show no site-specific infection reduction. Use coatings as a bonus and not as a crutch. Technique and knot mechanics. Poor knot security and excessive tension increase tissue trauma and weakening. Choose the right gauge. Use low memory filaments with adequate throats and avoid strangulation of the soft tissue. Let's look at some studies on material comparisons. PTFE versus silk, and a study on third-molar sites where we see that PTFE accumulates less aerobic and anaerobic biofilm than silk, and I guess that applies to everywhere in the mouth. So you should expect less local inflammation with PTFE, for example. Monofilament versus braided in oral mucosa. Multifilaments trigger stronger inflammatory reactions than monofilaments in vivo. PVDF and synthetic options often show milder tissue reactions than natural materials. The global view is that all sutures can cause biofilm, but magnitude varies by material and filament type. So braided vicryl and some polyamides show higher counts in vitro. How about antibacterial coated sutures? Should we use them? General surgery meta-analysis show triclosan coated sutures lower site-specific infection risk across procedures. The oral surgery data we have show that the results are inconsistent. At least one dental implant randomized clinical trial found no site-specific infection reduction with triclosan coated vicryl. Use only if contamination risks are high or patient factors push site-specific infection risk up, but do not expect large effects in clean intraoral sites. There are emerging coatings out there. Early reports on silver and other coatings show antimicrobial promise, but clinical endpoints in the mouth remain limited. So when it comes to monofilaments and knot security, we know that the knots can slip. So we have to compensate with proper sequence, longer tails, and stable hand positioning. We need to keep tension just enough to approximate without blanching the soft tissue. You need to check tensile behavior of your chosen brand in wet conditions. Let's talk about dehiscence, a spitting stitch minimization. So we need to avoid burying bulky knots over thin biotypes. We need to keep bite symmetric and tension balanced to resist micro movement. Plan early removal of non-essential sutures to reduce plaque maturity. And also we need to give clear instructions to the patients. We need to tell them to avoid hard brushing around the line of sutures, only soft brushing for the first at least 24 to 48 hours, and avoid chlorhexidine unless indicated and short-term, and strict avoidance of foot trapping at knot sites. Less plug on sutures equals less inflammation. So bottom line, pick monofilament synthetics for low inflammation. Add throws for security. Consider coatings only as adjuncts, and technique and hygiene still dominate your outcomes. Need a suturing tutorial next? Please type sutures below, and please like and subscribe. Thank you.